Great. Good morning, everyone. Hello, hello. I am so thrilled that we have a packed house today. This is great. I'm Chris Rebelo. I am the Senior Director of Communications here at the Buck Institute. I am thrilled to welcome you today in the spirit of back to school, because that's what it feels like to me. Today we're going to learn something. We're going to learn how to be your own geriatrician. A couple of quick housekeeping notes before we launch into it. If you haven't put your phones on silent, please do so. And then also, I always like to keep the fire marshal happy by pointing out the emergency exits at the back of the auditorium. So my first question, is there anybody here who's new to the Buck? Great. So we love folks who are here for the first time. We love all of you, but it's great to have new people. So rather than me kind of blathering on about how great our scientists are, I'm going to show you a video that actually features the people who are doing the work. Jorn, go for it.
The Buck. The Buck Institute is interested in understanding aging, not only to make us live longer, but to actually alleviate and suppress the development of diseases.
Chronic disease is the great health challenge of our time. Aging is the main driver of chronic disease. To eliminate chronic disease, we must harness the biology of aging so we can live healthy longer. The Buck Institute is the world's first research organization dedicated solely to the biology of aging. We work with the building blocks of biology to understand how we age.
The Buck is concentrating on really trying to go to the root of the problem, so understanding that we can sort of intervene really early.
The Buck Institute is probably the best place in the world to be working on aging because there's so many different aspects of aging that are being studied. It's key because no one lab can do it all.
Our scientific explorers are brilliant, curious, and committed.
The idea that you could actually develop drugs that slow down the aging process was really something that 20 or 30 years ago people thought this cannot be done. Not only can it be done, but we will do it.
The pieces are in place. And we are in a unique position to put them together. Our world is defined by paradigm shifts, created by scientific discoveries. The biology of aging is the next frontier.
We're working toward a world where healthcare is better. It's a world where if we can eradicate the aging component to disease, we're all going to live healthier and longer.
It's just an incredible vision that really will, surpass anything else that we've ever seen before.
We are inviting you to a future of aging without illness. It's happening today, and it's happening here. Join us.
Okay, so before I introduce today's speaker, I want to thank all the sponsors. They are listed in your program. We really do appreciate their support. I encourage you to take advantage of their businesses if it makes sense to you. I also want to make sure everybody has note cards. That's how we're going to handle Q&A. If you have a question, write it down, raise your hand. A volunteer will come around and pick it up. You can ask a question at any point during the event. We have a lot of folks on Zoom today. I think we may have set a record for folks on Zoom. So welcome, you too. Get to ask questions. Just put them in the Q&A section and somebody will get those questions up to me here on the stage. So, it is now my pleasure to introduce Dr. John Newman. In addition to running a lab here at the Buck focused on developing treatments for geriatric syndromes of aging, John is also a practicing geriatrician at UCSF. His focus there is on preserving mobility and preventing delirium in older adults. You can read about John's educational background in your program. He went to Yale. I want you to know how rare and how valuable this guy is to have here at the Buck. There are just a handful, really a handful of researcher physicians studying the aging space. So John interacts with older adults. In addition to his work here on our clinical research program, we'll talk about that a little later, he's also involved in national efforts to make it easier to get interventions to the clinic where they will help us all. So, John, come on up.
Thank you, Chris. That was a very kind introduction.
Sure. So, can everybody hear us okay? If you have a problem, don't be shy, raise your hand. Also, John is an MD. I need to point out that he's not your doctor. So he is not wearing a lab coat, a white coat. He doesn't have a stethoscope around his neck. So we welcome your questions. Just be sure that they're general in nature. This is not the place for second or third opinions. Okay, so John, oh yes. So this event is being recorded. So there's no need for you to take notes. You will get a link, you will see the video, and there's going to be a number of resources that we talk about today. You're going to get links to all of that. So kick back, enjoy yourself, and ask good questions. Okay, so let's see. Let us go to this one. So John, people want to learn how to be their own geriatrician. What's different about geriatricians from most docs?
Who's heard of geriatricians? This is amazing, Chris.
I told you they were smart.
When I introduce myself in the hospital, probably half the time people ask if I'm going to help them make out their menu for lunch. And maybe 1 in 10 actually says, "Oh, you're a doctor for older people." So this is amazing. What is geriatrics? What makes a geriatrician? And the whole hour is going to be me trying to kind of brain dump into all of you. How can you think like a geriatrician as you approach your healthcare? And thank you all for coming. I hope this is going to be a really fun and interesting hour. And yeah, please feel free to jot questions as we're talking. So what makes a geriatrician? Why are we different? Most doctors are organ doctors, and you guys probably all see lots of different organ doctors. Doctors who specialize in your heart, or specialize in your kidneys, or specialize in your lungs. Geriatricians specialize in you. We see our job as integrating everything about you to try to figure out the best way to help you do the things that you want to do as long as you can do them. I kind of have feelings about this, Chris. We talk a lot about personalized medicine and these days health span extension, like we were just talking about. Geriatricians are the original personalized precision medicine. We want to figure out what's special about you, what's unique about you, and how can we tailor your medical care to do the things that you want to do. And that's the health span extension part, about accomplishing your goals and letting you do what's important to you as long as you can. So we are the original precision medicine and original health span.
I understand that there is a shortage of geriatricians in this country.
Yeah, so all of you have heard of what a geriatrician is. Who's seen one as a doctor? Yeah,
wow.
That doesn't surprise me at all. There are something like 3,000 geriatricians in the entire United States. That number hasn't changed in decades, and if anything, may be slowly dropping. So there are not nearly enough geriatricians for even for the people who most could benefit from seeing a geriatrician, which is why we do things like this. A lot of geriatricians you'll find in leadership roles in healthcare systems and in medical centers. A lot of us are involved in teaching and education, not just teaching students, but teaching other doctors. So we try to geriatricize the world around us. And that's how we can have more of an impact, because unfortunately we can't possibly see everyone that might benefit from us.
So, perfect lead-in. There is, I say the cavalry is on the way. So there's a great program that has been launched across the country that is designed to bring age-friendly healthcare into the clinic. And today's event is going to be loosely organized around the 4 M's of age-friendly health systems: what matters, your medication, your mind and sense of well-being, and your mobility. You will get a link to download a really great brochure that will help you think like a geriatrician and get prepared for doctor's events. So just know about that. The first one that people really need to think about is what matters to you. This may be the hardest one because, we're trained to defer to doctors, and we're trained to really not ask ourselves what matters. So when you deal with patients, John, what's your take on this?
Well, what matters to you is what drives your health care. And yeah, we're used to looking to the doctor to say, well, what do I need to do? What's most important to improve my health? But what does that mean exactly? What part of your health is most important? What in your day-to-day life? What do you most enjoy doing? What do you want to most be able to maintain or get back to doing? And then that drives the decision-making about where to focus your medical care. A couple of slides ago, we had all these arrows pointing all together, which, geriatricians embrace the complexity of an older adult. And many of you probably experience this. There's a lot going on in your health usually. And you're seeing all these different doctors who are looking at all these different organs, and how do you know which is the most important thing? What problem to focus on? What new medicine to try? Well, that's based on your goals. What's most important for you to be able to do? For example, if it's really important to you to be able to keep going for hikes with your grandkids or your granddogs, what among your medical problems is most affecting your breathing and endurance when you're walking? Is it the heart valve? Is it the COPD? Is it maybe some dizziness from a medication side effect? Is it something else? Which of those do you focus on first? That's driven by your goals. What are you trying to accomplish? What among all the different things that might be at work is maybe the most important, or the thing to focus on first? And then you do that. We know that you can't try to do everything about everything. If you try to do too much, you're going to wind up doing harm. But if the key to being a geriatrician is trying to figure out what is that one screw we need to turn just a bit, and help you to do the things that matter the most to you.
So, the next time you go to see your doctor or a healthcare practitioner, I'm really encouraging folks to be proactive. Have in mind what matters to you.
Yeah.
And it might be on a day, today what matters to me is picking up this new medication. Can you help me do that? Long term, I want to go to my granddaughter's wedding in 3 months. Can you help me get in shape to do that? So it always comes back to the personal.
Yeah.
Okay, so now we are going to get into medications. Talk about aging physiology, John. Why? What happens as we age that makes us more susceptible to issues with medications?
Yeah, a few different things, and these things change as we get older, even if the medicines stay the same. But I always want to say up front, medicines save lives. My favorite example of this is, how old was FDR when he died? He was such an old man when he was president, right? And he died of a stroke brought on by uncontrolled high blood pressure. How old was he? Does it? 63. He was only 63. And we didn't have good medicines for treating blood pressure then. We have lots of good medicines for treating blood pressure now. He would have surely made it into his 80s if he had modern blood pressure medicines, if not making it to 100. So medicines save lives. But geriatricians also know that if you do too much of anything, too many medicines can cause harm too. And medicines are always a trade-off between trying to do good and trying to prevent harm. So what can happen to cause harm? Our bodies change, even as the medicines we take don't. And we respond to medicines differently than younger people. And some of this is really rooted in biology and physiology. You know, the composition of our bodies change as we get older. And we all kind of notice this, don't we? We start to lose muscle mass. We start to gain a little more fat tissue in places we don't want it, maybe. But that affects how drugs are absorbed, metabolized, and released throughout your body. So the same drug at the same dose that you were taking 20 years ago may have different effects on you today, not because the dose has changed, but because the way your body processes that dose has changed. We also know, for example, that our kidney function declines slowly but gradually as we get older, and our liver function can change too. And these are the two main organs that process drugs. Sometimes your liver is required to convert a drug into an active form. So if your liver does that more slowly, it's like you're taking a lower dose, even though the dose is the same. And many medicines are removed from your body through the kidneys. So if your kidneys aren't working as well, if the function is slowly declining, it's as if you're taking a higher dose. It sticks around longer, even though the pill hasn't changed. So all these things change over time. We get a little bit less resilient to side effects. So the sort of side effect that a younger person might barely notice, or my head feels a bit weird today, but I can still do my thing. I can still go for a walk. I can still do my job. But when you're older, because of everything else that's going on, that same side effect might affect you more dramatically. You know, your head doesn't quite feel right, but because of the atrial fibrillation and maybe because of another medicine you're taking, that's enough to make you dizzy and make you unsteady and cause a fall. So we're less able to cope with side effects as we get older. So for all these reasons, it's important to think a little bit differently about medicines as we get older.
And also, not casting aspersions, but most doctors aren't trained to really understand what's going on in the aging body, right? I mean,
yeah. And most doctors, to be honest, we like to leave stuff alone. And if you've been on a medicine for 20 years, why would we think about it? But it's always good practice to sit down with your doctor once in a while and just go through all the medicines. Is this still helping me? Do I still need this? Is it still working? Do I need the same dose? Could it be now maybe doing a little more harm than good or a little more good than harm? And just thinking through that consciously once in a while. That's a key part of the 4 M's.
So if there is one thing, so first I want to talk about, there's a handout that you're going to get a link to. It's called the Beers Criteria. It is a list of 10 medications that older adults should either avoid or use with caution. The last time John and I did this, we talked about pain medications and we talked about some over-the-counter drugs. There will be a link to that event. So if you want to know more, you can go back and look at that one. Today, one of the things that's on the list is aspirin. So what's the deal with aspirin? Because, there for a while it was like, everybody's got to take a baby aspirin.
Aspirin's a great example of how we've been learning more about how best to use a medicine, specifically in older adults, which is still too rare of a thing, Chris. We'll talk about clinical trials at the Buck later, but the reality is that older people have still not been included in enough clinical research to really know how to use a lot of medicines to the benefit of older people specifically. Instead, we often see these recommendations that's up until age 70 or 75 or so, very clear, do this, do that, under these conditions, but then over 70 or 75, big question mark. And that's really frustrating, especially when for common things like heart problems. Most people who experience these are older. So why don't we know more? Aspirin, we are starting to learn more. Aspirin is very commonly used to try to prevent heart problems. It's also used to try to prevent a second heart problem if you already have heart disease. And we're not talking about that. Aspirin definitely has important roles if you've had a heart attack, if you've had bypass surgery, things like that. But a lot of people take it who have not had a heart problem, trying to just prevent their first heart attack. And we've learned that the people who really benefit from that, it's a little narrower than we used to think. And this is because we finally have large randomized controlled trials of people without heart disease taking aspirin or not, taking a placebo, and then seeing what happens over a number of years. And of course, we know aspirin can cause problems. It can cause bleeding. That's literally how it works. It helps to stop clotting in the vessels around your heart, but that means it can stop clotting in other places too when you want your blood to clot. So aspirin's always a trade-off between preventing clots that you don't want and not having bleeding that you don't want. And now we know that in people under 75, that trade-off can be worth it if you're at high enough risk for heart problems. If your cholesterol is high, your blood pressure is high, you have a family history. If you have none of that, you probably aren't benefiting from aspirin and you're only getting the downsides of bleeding. If you're over 75 though, that risk benefit seems to shift. And we actually have data for this now. That the bleeding still happens and actually probably happens a little more and is more serious when it does. But the benefit in people who have never had a heart attack is lower. So the recommendations now are if you're over 75, you probably shouldn't be taking aspirin to try to prevent a first heart attack. You should be doing other stuff, and we'll talk about this. You should be active, you should be exercising, you should be controlling your blood pressure, all these great things, but probably not aspirin.
Great. So if there is one takeaway from today, I want this to be the one for you. A new symptom is a side effect of medication until proven otherwise. Beware of the prescribing cascade. What are we talking about, John? And we have an example here.
This is one of the first things that one of my mentors taught me as a fellow 15 years ago. That mentor now helps to write the Beers list for the American Geriatric Society, and he runs his name is Dr. Michael Steinman, and he runs a national network to try to understand it's called the National De-Prescribing Network. And it's the idea that, who's ever heard of that, right? Medicines help, medicines save lives, but sometimes if you're taking a lot of medicines, it might actually be helpful to take one away. So he studies how to do that. And this is the idea that if you're taking a lot of medicines, then new symptoms may well be side effects, and your doctor should always be thinking about, of course, what else might be causing it, but is it one of the medicines, and could your health actually benefit from stopping something instead of adding something else? And our nightmare is the prescribing cascade, and this really happens. When something comes up that turns out to be a medication side effect, but you go see a doctor for this, and there's always a pill for anything, right? So you have a new symptom, you get prescribed another pill, you have a new problem, it turns out that's a side effect of the second pill, you get another pill, and but it's all side effects all the way down.
So this is a real example, right?
These are examples taken from real patients that I saw in the hospital. Visiting, so if you ask me, Chris, what is the one medicine, and it's an over-the-counter medicine, that I really, really wish everyone knew about and everyone was more careful about? This is on the Beers list. It's diphenhydramine. Diphenhydramine is an antihistamine. It's an allergy medicine. Very commonly used, but in older, and it's sedating. So it's not just in allergy medicines, it's the most common ingredient in over-the-counter sleeping pills. And the problem is that it's not just sedating, it hits a lot of different receptors in your brain and can cause lots of different side effects called anticholinergic side effects. It doesn't just make you sleepy, it makes you confused. It can actually affect your memory. It can cause dry mouth, it can cause heart problems, it can cause gut problems, it can cause bladder problems. If you take a lot of medicines like this, a lot of anticholinergics, it actually, over the course of your life, it actually increases your risk of getting dementia from too much exposure to these over-the-counter anticholinergics.
So those are all of those PM drugs, right?
Yeah. Geriatricians do not like the PM drugs. Not at all.
So what happened in this case?
So here's an example. Someone who has trouble sleeping, took a couple of different over-the-counter sleep medicines, took a couple of pills from each, wound up getting a pretty good dose of diphenhydramine, and is dizzy, is starting to fall. So why is he dizzy? And maybe he goes to a doctor to talk about his dizziness. There is a pill for that, a pill called meclizine. Meclizine is similar to diphenhydramine. It's also a sedating anticholinergic antihistamine drug. So it makes this poor person even more confused. After a few weeks or a few months, maybe his wife brings him in to the doctor to say, something is wrong. I think he might have dementia. So, okay, we'll do some testing, but there's a pill for that too. We'll give you a pill for Alzheimer's disease called donepezil. The trouble with donepezil, though, and this is also based on a real case, these aren't all the same person, but they're all based on real cases. Donepezil can slow your heart down. And we actually saw this once, a person who almost got a pacemaker because their heart was beating too slowly, but when we stopped their donepezil, their heart picked back up and they were fine. They didn't need a pacemaker. It was just a medication side effect. So you start with an over-the-counter sleeping pill, you go with a dizziness medicine, then you go with the memory medicine, and before you know it, you're diagnosed with dementia, you have a pacemaker, you have heart problems, and all of this is just side effects of medicine, and it should have stopped right at the beginning.
The last time we were together, we talked about a prescribing cascade that started with a blood pressure medication. So go back and take a look if you're on blood pressure medication. That might be something you're interested in. I'm getting great questions. Somebody wants to know, it's related to medications, about antidepressants and older people. What's the recommendation? What's your take on them?
Yeah, so we know that fortunately we tend to get happier as we get older. Older adults are actually the happiest people. And it's also true, and we think that's part of appreciating our sense of accomplishment in life. You're able to reflect and look back, maybe not so much worry about the future. But it's also true that older adults can be at risk for depression. And this is often unappreciated and underdiagnosed because it looks different in older people than in younger people. In older people, it's more about feelings of loneliness and isolation and purposelessness, not having meaning anymore, thinking you're feeling worthless. And not even so much the classic, I feel really sad and depressed kind of mood. So it manifests differently. But depression is really important in older people. I think even more so in younger people, because it affects all of you. We have a term in geriatrics called pseudo-dementia. Pseudo-dementia. Pseudo means like, fake, similar. So like dementia, but not dementia. And this is what you can see when an older person is really depressed. It can very much be indistinguishable from someone with advanced dementia, except it's a dementia you can cure. So screening for depression is really important. And treating depression is really important. Antidepressants can be great tools. Like we've been talking about for geriatricians, we always want to try to do the narrowest, most focused thing. So some antidepressants have more side effects than others. Sometimes those are thought of as good side effects. It'll help you sleep, it'll help you lose weight, but we'd like to stick with, let's try to just treat the depression and not cause or even take advantage of other side effects.
So before we move on, I can't tell you, I've gotten at least 4 questions from people who are wondering what to do about lack of sleep. Who has issues with sleep? So yeah, me too.
Yeah.
So what's a geriatric take on how to deal with sleep issues?
Yeah, so a few things. First, of course, figuring out if there are new medical problems that might be affecting your sleep. Things like sleep apnea is very common and very treatable. Other things like restless leg syndrome, or depression and anxiety. So what might be going on medically that might be affecting your sleep? But once you kind of get past that and you're really just thinking about sleep itself, this is actually an area where we have a lot of high quality data from randomized controlled trials that Chris, I would have loved to be in, because they're randomized controlled trials of things like comparing a sleeping pill to a combination of a glass of warm milk, calming music, and a shoulder rub. That was a real randomized controlled trial done in Europe. Who thinks that the sleeping pill was better? Who thinks that the warm beverage? Yes, so being a little funny about it, but the principle is that non-pharmacologic, some people call that sleep hygiene, treatments without pills, is actually more effective than sleeping pills. Trying to stay awake and be more active during the day, having a routine to kind of let yourself gradually get down into bedtime, calming activities in the evening, not drinking too much water or especially alcohol later in the evening so you don't have to get up to pee right away, calming activities before bedtime. All of that is actually much more effective than sleeping pills and doesn't have side effects, except in a good way. Being more active and exercising more during the day will help you sleep better and has lots of other good effects on your health too, as opposed to most sleeping aids will have some sort of side effects that may not be good for your health.
Got it. Okay, whoops, got to go back one. So,
and this is not just true at home. These are also the approaches that we use when people are in the hospital to try to help them sleep better through the night so that they heal faster and so they don't get delirium.
So, delirium.
What good timing.
I know. How about that? I had no idea what delirium was before I met you and we started doing this. I was aware of the term, deliriously happy, but that ain't delirium. So what is delirium and how does it manifest in older adults?
Delirium is one of the most common serious problems that probably many of you have seen, but didn't know what it was. So delirium is what happens when an older relative, an older friend, gets sick, goes to the hospital, and they are suddenly a different person. They're seeing things, they're hallucinating, they don't know where they are, they're misinterpreting what's happening around them, they don't understand what's going on, they think that a nurse coming to draw their blood is trying to cut their arm off, they're paranoid, they think everyone is trying to hurt them, to steal from them, and this is not them. They were perfectly normal 2 days ago, and now they're totally different. So that's delirium. Delirium is an acute confusional state that's brought on by sickness. And it's reversible if you treat the problem that triggered it, and that could be all sorts of things. It could be an infection, it could be a heart attack, it could be a stroke, it could be the wrong medicine. But if you fix the problem that triggered it, the delirium will usually get better. The faster you fix it, the faster it gets better. But it's really uncomfortable to experience. Obviously, it makes medical care really challenging because person doesn't know what's happening to them. And it still has long-term effects. It increases your chance of getting dementia down the line. It increases your chance of dying over the next year or two. So it's a really serious, unappreciated problem.
So delirium often happens in the hospital, in the emergency department. There will be a link to this great tip sheet on what would be featured in a geriatric-friendly emergency department. There are very few of them. UCSF has one.
Yeah.
Good for UCSF. Yeah. So ideally, what should people expect when they go to a geriatric-friendly emergency department? And if there is not one, what should they ask for?
Well, maybe the first thing is what should you bring with you to make it more geriatric friendly? We'll talk about that in a second.
Okay, great. Yes.
But I heard some chuckles when you mentioned geriatric-friendly emergency departments, because that sounds like an oxymoron, right? How can an ER be friendly for older adults? But that's the point. So talking about delirium, for example, delirium is caused by a medical problem. Something new that's triggering it, something that you can find and fix. But it's much more likely to happen in an environment where your brain is kind of being bombarded from all sides by unusual stuff. So if you're not sleeping, if you're not eating and drinking, if you're being woken up all through the night, if you're being poked and prodded and lines coming out every orifice, if you're not getting out of bed, if it's an unfamiliar place, lots of strange people around you, all these things make delirium a lot more likely. And it turns out that you can actually prevent a lot of delirium by addressing all those things and making the emergency room or the hospital a more friendly and home-like place. That's actually good medicine. It's good medicine for everyone, but it's especially important and obviously important for older adults. So things like having doctors and nurses who are trained in the medical problems of older adults, who will screen people for cognitive impairment, who will ask you about falls, who will ask you about urinary incontinence, for example, who will screen you for delirium and actually see if you are delirious and if that needs to be addressed immediately. Things like protocols around helping you sleep at night, even in the emergency room, especially in the emergency room, if you're staying in the emergency room overnight. Making sure that you are getting out of bed, even in the emergency room, and you are walking. One day, 24 hours spent in bed, and you can lose up to about 3% of your leg strength from just one day. So even one day in the ER, and you could be 3% weaker, and then 2 more days in the hospital, and maybe it's 4 or 5 days in the hospital, and suddenly you have trouble walking up a flight of stairs.
So the last event that I did with John, we talked about mobility when you are in the hospital. So if you have that on your radar screen, be sure to go back because there's really valuable information. Before we move on, one thing I want to talk about with delirium that I was shocked to find out is dehydration, right? That's a risk factor.
Yeah, it is.
When you go to the emergency room, they don't always make it easy for you to be able to drink, right?
Right. Yeah, dehydration is often the thing that we forget about. There's 5 or 6 things that we know from randomized controlled trials published in journals like the New England Journal of Medicine, gold standard, best evidence there can be. There's 5 or 6 things that we know help prevent delirium. One of them is sleeping better. In other words, the hospital environment enabling you to sleep by, for example, turning off the lights at night. Another is being more awake and active during the day. Having natural sunlight during the day, getting out of bed, walking and exercise, out of bed activity helps to prevent delirium. Being careful with medications that can affect your brain, that can sedate you or make the delirium worse. But the one we always forget is dehydration. And dehydration is very common when you're sick. We're kind of, and part of that is because you're not feeling well. Part of that is because at the hospital environment, are you allowed to get up out of bed and get a glass of water for yourself? Where's the sink? How do you get that? So dehydration can be very common, and it contributes to delirium, and it's very fixable. The best fix for dehydration is just enabling people to drink water and encouraging them, helping them to do that if needed. But if on those occasions where you really shouldn't be drinking anything, because maybe there's a surgery planned, making sure that we're doing other things like IV hydration to prevent you from being dehydrated. But hydration is really important.
Great. Okay, so if you need to go to the emergency department, what's your advice to folks?
Have your go bag ready and bring it with you. Remember that you might be in the emergency department for a little while. I know that's a surprise. But you may be there a while. And of course, anytime you go to the emergency department, you may wind up being admitted to the hospital. So be ready for that. Simple things, like you want to be able to see and hear what's going on. I know people are of course worried about losing things, but have a pair of glasses you can bring. Bring your hearing aids. If you are worried about losing your hearing aids, have a pocket talker. This is it's very much like the devices we're wearing right now. It's a little gadget, a little box that's hooked up to a microphone with a set of headphones. You can find them on Amazon for $50 or so. And someone can speak into the microphone and it's amplified into the headphones you wear. So if you're hard of hearing, that can actually help you hear what's going on. Make sure you bring your list of medications. This is maybe one of the most common things that people are surprised about. You probably think, well, my doctors ought to know my medications. It's all in the computer, right? It's there. All of it's there. All the different lists, none of which are the same as each other. There's the list from the pharmacy, the list from the last hospitalization, the list from the primary care doctor. The only way we know for sure what medicines you're taking are if you tell us. If you have the list that you look at every day as you take your medicines. So you should have a list like that, and please bring it with you so that we know exactly what you're actually taking. Your advanced directives. We were talking earlier about what matters to you, and if things are really serious, what matters to you should be things like, if I can't speak for myself, who is going to help the doctors make medical decisions for me? And what do I want those medical decisions to be? What kind of care do I want or not want? And if it came to it, where and how do I want to die? That's a really important decision, and that's up to you. So it's important to write these things down in advance, because by the time you really need it, it's too late. And make sure you bring it with you, always, every time you go to the ER. And make sure that your friend, your advocate, your family member has a copy too.
So the last note on this slide gets back to, I think, what matters. It's have a voice.
Yeah.
How does what matter factor into a trip to the emergency department?
Yeah, so have a voice. There's two pieces to that. One, I just alluded to your advocate, your friend, your family member. Bring your advocate with you. Bring someone with you when you go to the ER, when you go to the hospital. You're sick. You're going to have trouble following everything that's going on. You should be focused as much as you can on yourself. You need help. You need someone there to listen to the doctors, to ask the questions that need to be asked, to help you take notes. Bring that person with you to help be your voice. And make sure that person knows what's important to you. You may have very strong feelings about whether you want to be in the hospital at all, about whether you want to be in an intensive care unit on machines, or just what your goal is for going to the emergency room. Maybe you're having a bad symptom and you want to feel better, but maybe you don't necessarily want to dive deep and know what's causing it. Maybe you just don't want to know that. That's okay. That's your choice. But you're in control of these things. So you should feel comfortable expressing to the doctors what you want out of that emergency room visit, what you're hoping to achieve, and then your advocate can help make sure that that's the way that the care goes, that you're in charge.
So when you and I were discussing content for today, you also, it's not on this slide, but that it is, stay with the adult who is admitted, or at least do not drop them off. So does that really happen?
It does. Yeah, it does. And to be fair, Chris, I can't always blame people for it, because caregiver burnout is a real awful thing, and it's very common, and if people can't get a break, caregiving can be a 24-hour exhausting job, and they're in the hospital now, someone is looking after them, and it's not just I can go kick back and have a beer, but caregivers have a hard time tending to their own medical needs, seeing their own doctors, buying groceries even. So I don't want to blame anyone for that, but it is really hard to care for someone, especially if they're delirious or they have dementia. So either way, they don't necessarily know what's going on and have a hard time expressing what's happening to them. So it's really hard for the doctors to know what's going on unless we can talk to other people, talk to the caregivers, talk to the family. And the ER, hospitals, they're such strange, unwelcoming places. And having a familiar face that the person trusts, especially if they have dementia, especially if they're delirious, can really make a huge difference in their care. It can help everything go more smoothly from the medical side, and it keeps the person, the patient, much more comfortable because they're reassured by the familiar face. So, having that loved one who cares for them in the room with them is often, it's good medicine. I wish I could prescribe that. But if nothing else, please make sure that the doctors know how to get in touch with you so we can find out what's going on.
That's great. Okay, we're going to talk about mobility now. A question, who here would really prefer to age in place? Right. So, if you want to do that, the best way to do that is to slow your functional decline. Talk about mobility, John.
Yeah, and the best way to do that is to stay active and to be a little more active than you are today, and to do it safely. So we know that exercise is the best medicine, and I don't even like the word exercise anymore, Chris, because it's not about like going to the gym and doing reps and whatever, but it's just being a little more active than you are today. And the day-to-day activity, the walking around your house, the taking your dog for a walk, just a little bit more activity makes a big difference in your health. Activity, exercise, it helps with heart disease. It helps with dementia and Alzheimer's disease. The best way to prevent a fall isn't to stop walking. Even in the hospital, don't get me started about that. The best way to prevent a fall is to become stronger and to train your balance. In other words, the best way to prevent falls is to exercise, to be more active, not less active. So this is really important, and it affects every part of your life. If you ask me what's the single most important thing to help us live better longer, help us age more healthy, it's being more active, because that affects everything else in your life. Everything affects everything else in geriatrics. This is one of those things that's a good thing. Being more active, exercising more, it affects every other piece of your health.
Let's talk a little bit about ensuring home safety. So Medicare will cover a home visit, right, with an occupational therapist, I've been told, to check out if your situation is safe.
Yeah. This is something that maybe a lot of people haven't heard about, although it's been there since Medicare was created back in the 60s. Part of Medicare's benefits are to pay for skilled services like physical therapists and occupational therapists and nurses. If you're homebound, which the Medicare definition for that is not as strict as you might think. Just if it's difficult for you to leave your home, there are some criteria around that. But a lot of people, even if you're here, you might still meet those criteria. Medicare will pay for those occupational therapists, physical therapists to come visit you at home. One of the most impactful things that they can do is look around your house and help figure out how to make that environment safer for you to be more mobile. So helping you troubleshoot, like, what are the trip hazards in my house? That maybe that throw rug shouldn't be there. Maybe we should, if it's hard for you to reach certain things, maybe we can brainstorm about how to rearrange stuff in the closets and the cabinets. Where would you benefit from having grab bars? Maybe we need to put a bench in the shower, or order other durable medical equipment, or have a door in the bathtub, frames and seats around the toilets. What are all sorts of ways that we can help you stay independent, be more mobile, and keep your house functional? It's called a home safety assessment or home safety evaluation. And especially if you've had a fall, especially if your mobility is less than it used to be, your doctor may be able to prescribe that for you.
Great. Okay. So this is a perfect lead-in. I want to talk about John's work here at the Buck and beyond. So we have a slide here, an image about one of the clinical trials here that you're involved in, Takeoff. We have something about the X Prize, and we have somebody using a grip strength gizmo. How are these all related, John?
Because they're all about you. They're all about older adults. I think, so most of you have probably heard about the clinical research that started happening at Buck about 3 years ago. And this is really unique, I think, for a couple reasons. One is because we're really focused on the exciting cutting-edge biology of aging, on these molecular mechanisms that affect how we age. and trying to take all of the fascinating knowledge that scientists you saw in the video have worked out in the laboratory, in helping flies live longer and helping worms live longer and helping mice be stronger and independent, but figuring out how these things all work in people. That's really interesting. But I think the second exciting thing about the clinical research we do is that it's really focused on older adults as whole people. So for example, we're running a clinical trial that's based off of very basic science research done in my laboratory, the laboratory of Eric Verdin and some others, about ketone bodies. And about what kind of health benefits might we get from people taking ketone bodies for every day for 5 or 6 months. We're not doing that to try to treat Alzheimer's disease. We're not doing that to try to treat heart failure. We're not picking one organ. We're doing it to try to treat the whole older adult. So we're seeing if that will improve frailty. Frailty is when you're starting to slow down. Literally, so we can measure frailty by how fast you walk. New Yorkers don't get a bonus on that, just because but you're starting to slow down. Your body is less resilient and more vulnerable to when bad stuff happens. It affects you more. Frailty is a risk for becoming disabled. It's a risk for getting dementia. It represents the stuff about aging that we wish we could turn around. But it affects every organ in your body, and it's driven by every organ in your body. So that's what we want to try to improve, not just the heart, not just the brain, but the function of the whole person. That's the goal of the takeoff study, to see if ketone bodies can improve function in frailty.
The X Prize. So I'm going to brag on John and his team. They were among there were like 60 semifinalists for the X Prize, which is over $1 million, right?
$250,000. Quarter of a million
for right now. One can hope. So we've made it into the semifinals.
Very few teams. There were hundreds and hundreds of teams around the world that competed and applied, and we were one of about 40 semifinalists named around the world.
So what's the X Prize? What's your X Prize project focused on?
I think this is so cool, and I hope you guys do too, because the X Prize is kind of the synthesis, the putting together all the pieces that we've been talking about, and kind of everything that I think is cool about and impactful about the buck. So the goal of the X Prize, so I don't know if you guys have heard of the X Prize. It's a nonprofit foundation that collects philanthropic donations in order to put together cash prizes for ludicrously ambitious, audacious goals. So, and it's meant to be that way. So the very first X Prize about 20 years ago was for the first private enterprise, not a government, to put someone into space. And that was crazy at the time, but someone won it, and that wound up helping to launch the whole commercial space industry. So there are many different X Prizes. One of the more recent ones is X Prize Health Span. The goal of X Prize Health Span is to run a 1-year clinical trial that will turn back the clock on biological and physiological measures of aging by 10 to 20 years. Make people's brains function better, muscles work better, and immune system work better by 10 to 20 years in 1 year. Yeah, that's pretty audacious. Honestly, I'm not sure anyone's going to win the full prize. Turning back the clock 20 years is pretty ambitious. But I think someone's going to get close, and it may be us. So how would you do that? Well, you ask a geriatrician who is also a scientist how to get the most impact on the health of an older adult. And to me, it's everything we've talked about today, all of these things about careful whole person geriatric care, plus cutting edge science. So that's our approach for the X Prize. We're collaborating with a hospital at University of Toulouse in France, who are among the world leaders in geriatric medicine, and they help to develop a kind of multi-point intensive intervention for older adults that combines things like exercise training, cognitive training, social interaction and engagement, addressing depression and mood and purpose, watching medications, of course, and being careful about that, fixing hearing and vision problems, really the whole package to try to help someone be healthier from a geriatric care perspective. And I think that alone is really impactful. And we're going to find out through the X Prize just how impactful. But we're going to do more. We're going to add biology to that too, both to have a bigger impact and to try to enable all these other things to work better, to help the exercise to work better, help the cognitive training to work better. So we're about to start a small pilot version of this at University of Toulouse, which combines this geriatric care program called iCope with a ketone ester, to give ketone bodies, to try to give your cells, your bodies more energy, and help to target some of the mechanisms of aging to enable people to become more functional. That's just a pilot study. We're currently working on developing what are we going to do for a full year clinical trial that we think will have the most impact. And it's probably going to involve one of the drugs that we think has potential to be a gerotherapeutic. You saw in the video, Eric Verdin allude to this, the idea that, so right now, there are no drugs that are known to target aging and improve people's health. But there are several drugs that we think might be, based on how they've acted so far in clinical trials that have been done with them. These are candidates to be gerotherapeutics. We need to run clinical trials to test them and see if they really work, if they really address aging. We're going to try to do that in the X Prize. But not alone, combined with this multi-domain geriatric care program. Best of both worlds. I think that's what we have to do to have the biggest impact on people's health.
So there's a term that I have become familiar with, just learning about this myself, intrinsic capacity. So you guys should know about this and keep it in mind when you go to your doctor about what matters to you. So what's intrinsic capacity?
Intrinsic capacity is a way to answer this question of how do I measure my whole health? What does that really mean? And how can a doctor really sink their teeth into that? What does it mean to live better longer? So intrinsic capacity is a concept that represents everything that you and your body can do. And you want to do more. But it's broken down into a few different domains. So for example, one domain is sensory, your ability to hear and see. So of course you need to be able to hear what's going on in the world around you, you need to be able to see. If you fix those problems, if you fix hearing problems, you can help prevent dementia. If you fix vision problems, you can stay more active. But 5 domains altogether, activity, nutrition, psychological health, cognitive health, and sensory health. So it provides this framework it's specific, it's quantitative. You can figure out what to do for each of these domains, but then it comes together in a coherent whole picture of your overall health. You're going to hear a lot about intrinsic capacity, in part because I just alluded to this idea that maybe there are drugs out there that target aging. And that could be gerotherapeutics. Well, how do you get a drug like that approved by the FDA? Well, actually, age-related decline in intrinsic capacity is a diagnosis. It's part of the big diagnostic manual that all doctors and hospitals use. So it's an example of, and we can measure it using quantitative research tools. So it may well be that a drug for intrinsic capacity might be the first drug that winds up getting approved to target aging broadly. And
we are helping lead the way here at the Buck. So we are just about out of time. We need to do a whole event just on medications. People have so many questions about medications. This one had, and I also got a question about this. So the question is kind of like, let's get real. Yeah, sure, my doctor's going to have time for me to talk about what matters. What do you do if you go to the doctor and they're like, okay, how's your blood pressure? How's this? How's that? What do you do?
Tell them first. Tell them before they have a chance to dive into everything else. And I mean it. Think ahead of time, what is your agenda for that visit? And then, make sure that first thing when the doctor walks into the room that you tell them, or you can ask them, what's our agenda for today? I have something. Or tell them, I know you have things you want to talk about. I want to make sure we get to this. And doctors actually like that. We especially like it if you do it right up front, because then we know how to spend those 15 minutes. My goodness, I can't even imagine. But it's way better to hear that up front than the classic doorknob moment. The doctor goes through the whole visit, they're talking the whole time, you barely get a word in, but we've talked about your blood pressure, your vaccines, we talked about your cancer screening, we talked about the heart failure, and okay, great, we're done, I helped. But then at the last second, I'm walking out the door, feeling all good about myself, and then you say, wait a sec, just a sec, there's something else. And it turns out, it always turns out this way. It's by far the most important thing that we should have talked about. So of course the doctor, and this has happened to me, comes back in, sits back down, and we take care of that. Say it up front. The doctor will actually like that. And of course the doctor will have opinions too. Let them say what they think their agenda is too, but get your word in.
Got it. So just a couple more questions. Most of us over 70 are forgetting names, appointments. Is that a precursor to dementia? Like, where's the red flag?
So mostly no. And I say this as someone who has a really hard time remembering names, which has been getting worse. That is a normal feature of aging. That's not a sign of dementia. When to think about talking to your doctor, if things are starting to get in the way of your day-to-day life, causing problems, and especially if it's short-term memory. Long-term memory is usually fine, but if it's like I can't remember what we talked about yesterday, I can't remember what I was supposed to do today, but like really in a way that is really noticeable and really affects how well you can get things done. We all walk into the room and then forget why we did. We all open up the fridge and then can't remember what we're going to take out. That's normal. That's normal. But if it becomes a pattern that's preventing you from being able to do your job or take care of your health. But in the meantime, how to cope with these little things that happen to all of us. There's the brain that's in my head, and then there's the brain that's in my pocket, right, or on the desk. It's okay. Use these things. We all develop systems for how to manage appointments, how to manage medicines, checklists. I love checklists. I use checklists for everything. I actually have a checklist on my office door in the hospital to remind me what I need on my person when I walk out to see people on the ward. Because otherwise I'll forget my stethoscope, I'll forget my ID badge, I'll forget my pen. That's really annoying. So checklists are your friend, lists in your phone, reminders. There's all sorts of tools that you can use as your external brains. That's perfectly normal. Take advantage of them.
So we live here in Marin, and I'm getting questions about non-medication things to do. I have a question about caloric dietary restriction, questions about supplements. How should people approach things that are like outside of what you might call the normal medical realm for somebody who goes, okay, I really want to give myself the best shot at aging well?
Yeah, there's a lot of things that are grounded in science. Caloric restriction is a great example. There's a lot of real science about caloric restriction and biological mechanisms of aging. I mean, that was the beginning of aging as a research field 100 years ago. And you guys have probably heard about caloric restriction before in other seminars. But that's one example of things that are grounded in real science, but where the data on how people can use them to improve their health are lagging behind still. There has been a large randomized controlled trial of caloric restriction in middle-aged adults of normal weight, so not trying to lose weight, which looked promising. But will caloric restriction really help you live longer, help delay cardiovascular disease, or help delay dementia? We're still looking for those data. But if you're not losing a lot of weight and you're staying active, it's probably not going to hurt you. A lot of these things that are grounded in science are probably not going to hurt you. If you want to try them out, make sure that you tell your doctor that you're doing it, especially supplements. Because remember, supplements, if it's having an effect on your body, it's medicine. And the only difference is we don't have as much data from large clinical trials to know exactly what it's doing, for good or for bad, but it's doing stuff. So make sure your doctor knows about all of the pills you're taking, prescribed, over-the-counter supplements, and everything. And join us, participate in the research, join us in the clinical trials, because there is so much exciting science that we just need to do the studies, to put in the work, to know how best to use it to improve the lives of everyone, especially older adults. We just need to do the work, and we need your help to do that.
Great. Thank you, John. So, here's what's going to happen next. You're going to get that follow-up email with all the resources from today's event. I am going to be back on October 1st. Our next seminar is with Dr. Dina Amira. She is a geneticist, an evolutionary geneticist. It's going to be a good one. I'm enjoying prepping for this. I promise you, after hearing her talk, you're going to look at the body a little differently, and you might even look at relationships in your family a little differently based on evolutionary genetics. So put that on your calendar. So, John talked about our clinical trials. Here is a listing of them. There are people out in the atrium afterwards. If you have any questions, you can talk to people on our clinical research unit about the trials to see which ones might be good for you. Anybody here involved in any of our clinical trials? All right, they're great, huh?
Thank you.
All right, yes, thank you. And please make inquiries about that. Okay, so I always say that the folks who come to these events are among the smartest in the Bay Area. So if you want to be even smarter, I would suggest you learn more about aging. We have a really great online learning class, and we're just getting ready to launch the 3rd season of our podcast called We're Not Getting Any Younger Yet. And that features experts from around the world. So it's a good listen. I recommend it highly. If you're new to the Buck, come on a tour. We do them twice a week on Tuesdays and Thursdays. We have a gorgeous building. You can learn all about IMP, and you can learn about our science. Keep up with us. Go on our website, sign up for our newsletter, follow us on social. And finally, I would be remiss if I did not ask you to please consider donating to the Buck. So John's first clinical trial here at the Buck got a jump start from a donor.
From one person.
One person
who was excited about our science, wanted to test and see if something had real effects in people, wanted to do a clinical trial. That was the first clinical trial that we did here at Buck, first ever. We couldn't have done it without that gift from one person. And that gift has been multiplied, 100-fold in terms of the research funding and the studies that we're doing now, from clinical trials funded by the US government, ARPA-H, NIH, foundations. It was the seed that just grew like crazy. You can have a huge impact.
I couldn't have said it better. So thank you so much for being here. I'll see you on October 1st.